Welcome, everyone, and thanks for joining us for a discussion on prioritizing community voices to enhance Medicaid policy and program design. My name is Rebecca Whitaker, and I am a research director at the Duke Margolis Institute for Health Policy. Our time together today coincides with ongoing discussions of federal Medicaid reforms, creating uncertainty for states as they navigate potential changes that could impact funding and coverage. At the same time, we know that state Medicaid agencies are continuing to push reforms that focus on efficient use of healthcare dollars, as well as changes to payment models, benefit design, and provider networks, along with stronger connections to social supports, with the recognition that these changes are essential for improving health and achieving smarter spending. These ongoing efforts can help support emerging federal priorities at the Department of Health and Human Services and the Centers for Medicare and Medicaid Services, including their strategic priorities around advancing evidence-based prevention, empowering individuals to achieve their health goals, and driving choice and competition. As we'll talk about today, prioritizing community voices in these state and federal policy reform efforts is critical. In particular, we'll be talking about how community voices can inform Medicaid value-based payment design, implementation, and oversight to advance health and well-being. Before we begin, we'd like to thank the Kate B. Reynolds Charitable Trust, whose funding has made this work possible. We'd also like to thank our project team and collaborators, including our Community Advisory Council, Duke's Department of Population Health Sciences, and the Duke Clinical Research Institute's Research Together program, as well as our partners at the North Carolina Department of Health and Human Services. Throughout today's webinar, please feel free to use the Q&A function to ask questions of the panelists. The webinar recording and slides will be available on the Duke Margolis website in 3 to 5 days. If you'd like to use the closed captioning for this webinar, please click the CC button at the bottom of your screen. Our goal for today is to share a portion of our research and feature a series of panels where we hear from individuals and organizations who are engaging in this important work within communities and policymaking. With that in mind, we'll first start with panelists discussing different approaches to incorporating community member voices in Medicaid policymaking, which is session 1. Then we'll highlight promising examples from North Carolina as well as other states in addressing this feedback using value-based payment levers in session 2. We'll then ask panelists in session 3 to react to a subset of policy options and discuss considerations for states and health plans and implementation. For context, North Carolina Medicaid, like other states, has been using value-based payment as a tool to advance its quality strategy focused on a more coordinated, whole-person system of care by gradually shifting Medicaid payments from fee-for-service to value under managed care. Value-based payment can help tailor health and social care to address Medicaid members' unique needs through flexibilities granted to Medicaid providers. However, we know that value-based payment models have not been historically designed with addressing the needs of these populations as a central goal. In the past, value-based payment design had been focused on identifying the best care model to promote health and then backing into the payment models that could support this preferred care model. This is a necessary but not sufficient step for using value-based payment to purchase health. We also need to be asking what people want and need to be healthy and identifying how we can design payment and care delivery models around this feedback. We hope to center today's conversation around what we heard from community members on the role that Medicaid benefits play in their health and well-being, identify priorities for collaboration with state Medicaid agencies, as well as elevate the steps North Carolina and other states are currently taking to address the broad range of health and social care needs that came out of our conversations. As I mentioned earlier, the magnitude of ongoing Medicaid reforms and state healthcare transformation efforts present an opportunity to listen to community members and prioritize what they want and need to achieve and maintain good health. Bringing together a variety of community perspectives, consumer advocates, healthcare providers, health plans, policymakers, and researchers creates a powerful opportunity for collaborating to improve health. With that, I'm going to pass it to Sam Repka to take us into our first panel of community engagement experts to hear how they are engaging Medicaid members and broader communities to learn about their healthcare experiences and what impacts that has had on policymaking. Over to you, Sam.
Great. Thanks, Rebecca, and good afternoon, everyone. My name is Samantha Repka, Research Associate at Duke Margolis, and I'm glad to be here with you today. Before we dive into the panel, as Rebecca noted, it's an important time to be talking about Medicaid As states work to improve programs and services, it's crucial to hear directly from community members about what's working, what's not, and how we can better meet their needs. With that in mind, we're starting today with a discussion of what are the ways organizations are engaging community members, some lessons learned, and how does that inform the policymaking process. So our panelists today bring a wide range of community engagement perspectives and roles, both formal and informal, all leveraging approaches to ensure community voices are heard and integrated within policymaking. In addition to having varying roles, our panelists are also translating that feedback to different audiences like state government, local officials, the healthcare system, and other community-facing organizations. And with that, I'm excited to briefly introduce our panelists while they're coming on screen, and we'll give them a chance to share more about their work once we dive into some questions. And so first, we have Rebecca Cerise, Health Policy Advocate with the North Carolina Justice Center. We also have Lowell Hamilton, who is the Senior Manager of Research and Community Engagement at United States of Care. Also joining us is Carolee Hall, who is the West Regional Associate Director of Partners in Health and Wholeness with the North Carolina Council of Churches, and also a member of our project Community Advisory Council. And finally, we have Laquana Palmer, who serves as Deputy Director, Communications and Engagement within the Division of Health Benefits at the North Carolina Department of Health and Human Services. And with that, I will give our panelists a moment here to come on screen. And Rebecca, I'm going to turn to you first. You've done work across North Carolina to amplify community voices in policymaking through efforts on Medicaid expansion, hospital consolidation, tools for managed care plans. Across your work, are there any specific examples you'd like to highlight in terms of how you engage community members?
Hello, everyone. Thank you so much for having me. Yeah, obviously, engaging community voices is essentially important. We design these programs, but if they're not working for people, then they're not working. And so we really need that feedback loop. We really need to understand what's working, and the best way to do that is going and talking to people because they are the experts in their own situations and their experiences. And, here at the North Carolina Justice Center, we really, really value that. A couple of examples that I want to talk about is last year we did some listening sessions with US of Care, and I know Lowell will go into more detail about this, but we chose four rural parts of the state, Rockingham County, Wayne County, Mitchell County, and Caldwell County. And we worked with local trusted community organizers to bring in people. We shared a meal. We compensated them. And this is going to be something you're going to hear me say over and over again because they are actually providing a service by bringing their experiences to the table. And so we believe that they should be compensated for that. And it's always good to share a meal. That is something that is just wired into our DNA, to share food together, break bread together, and show up together in those spaces. And so I'll let Lowell talk a little bit more about that, but wanted to say that. Another really great experience we had was when managed care first launched, and there was the managed care companies had to have member advisory councils. We worked with several partners on creating materials to, training materials so that when community members would be part of those member advisory committees, they would have the tools they needed to participate. And that's another really important point. It's like we don't want to just throw people into a situation that they're not comfortable with, that they're not familiar with, because they're not going to be able to show up as their best selves in that way. So we want to make sure that they understand what's going to happen. We have it really, so we did sort of best practices for how to run an accessible meeting for everybody. And then we really worked on a training specifically for members to talk about their stories, how to share their stories, what to talk about. And what I want to say is we wrote that with the best of intentions. And but we were like, we don't know if this is going to be effective for folks, if this is the way we've written it is actually going to work for people. So we actually worked with a smaller focus group. We worked with a partner who got several people, and we compensated them for them to go over this training. Well, guess what? We got terrible reviews, okay, on the training. But I was ecstatically happy about that because that's the reason we did it. I did not take it personally. I was like, yay, this is not working. So we went back to the drawing board. We addressed the issues that they came up with, and boom, we have a much more effective tool, which is really, really exciting. We did a similar thing with some of our outreach materials that and then worked with our DHHS partners to disseminate out when we were doing Medicaid implementation and enrollment, expansion enrollment, which we were so excited about. We wanted to do some different types of materials. We were very committed to enrolling every last eligible person, after that long fight we had. And so we came up with an idea to do these zines, these art zines. And we commissioned three local artists, but then we worked with directly impacted people who get health coverage through Medicaid. Again, they were the ones that chose the artists for us. A bunch of people came in and submitted samples. They're the ones that chose the artists for us. And then we had feedback sessions throughout to make sure, is this something that is effective for you? Is this something that's speaking to you? And we compensated them, of course, for that as well. So it's really about bringing people to the table, showing that you absolutely value their you know, what they're going to bring to the table, and compensating them fairly for their time. I just want to say one other thing, also, that was one of the most moving things that I've ever done in community, and that was a program called Photo Voice. We worked with Action NC in Fayetteville, and it was over a 9-week period where we met once a week. We brought cameras to folks, and we gave cameras to folks in the community. We compensated them. We gave them training about how to use the cameras. I worked with my friend who is an amazing photographer who gave them training about it. And then we asked them to go and film and shoot photos of what health looks like in their community or lack of health. And then every week we'd come together, we would have a meal, we'd talk about it, we'd look at photographs, and then at the end, we ended up having a community exhibition at the community center there in Fayetteville. And it was seriously one of the most powerful experiences I've ever had doing community engagement. It was long term, so it gave us a real opportunity to create real relationships with folks that I still have relationships with till this day, and get their perspective on what's going on and the things that we should be covering in our policy advocacy at the North Carolina Justice Center.
Thanks very much. I think it's really, hearing from you that this work is intentional, it takes time, and it can take different formats. And I think that's really, really helpful to hear. And I think a really nice transition. I'll turn to you, Lowell, next. Anything you'd like to, of course, build on the work with North Carolina Justice Center, but also would value hearing more about United States of Care work more broadly with other states. And so I'll turn to you.
Yeah, absolutely. Thank you, Sam, for the opportunity to just chat more about our work at United States of Care. I'm always so honored to discuss our collaborations with amazing organizations such as the North Carolina Justice Center. I think highly of Rebecca and her colleagues at NC Justice Center, and I think they are perfect examples of what thoughtful and strategic partnerships should look like. Regarding our listening work in North Carolina, as Rebecca stated, we conducted a series of community conversations across 4 counties. That was Caldwell, Mitchell, Rockingham, and Wayne. And our goal there was to understand how people were navigating a complex and increasingly unaffordable healthcare landscape, especially in light of Medicaid expansion. One of the most striking and unexpected findings from those conversations was how deeply healthcare consolidation, something that is often framed as a technical market level issue, was experienced as personal and disempowering. People often share stories of lost continuity of care, longer wait times, surprise facilities fees, and even the emotional toll of feeling small in the face of large hospital systems. These weren't abstract frustrations. They were heartbreaking accounts of medical debt, delayed care due to costs, and confusion around billing that left people feeling abandoned by the very system meant to support them. What was most powerful about this work was not just what we heard, but how it shaped our policy recommendations. And based on this engagement, it helped highlight actionable strategies that are presented in the report. And these included caps on facility fees, stronger protections against medical debt, enhanced oversight of hospital mergers to protect patient access and affordability. And these insights have become part of a broader conversation about what equitable healthcare should look like in the state. We've seen similar resonance in other states as well. In Colorado, for instance, our listening work contributed to recommendations of culturally responsive care requirements under the Colorado Option Plan. And there, patients shared how experiences of disrespect or lack of cultural understanding from providers often led them to delay or avoid care entirely. This feedback supported our policy recommendations of ensuring provider networks better reflect the communities they serve, not just in race or ethnicity, but also in language, lived experience, and communication style. And in both states, our community engagement approach didn't just validate existing concerns, it revealed deeper layers of people's experiences and surfaced practical solutions. And importantly, it reinforced that policies developed in partnership with communities, not just for them, are more likely to succeed. And this is precisely why at United States of Care, we believe that our people-centered approach is one of the most valuable tools in our toolkit.
Yeah, it's really helpful, and I think resonates with a lot of what we've heard as well. And as you've highlighted, the impact of taking this approach is really important to elevate. And so I'll turn now to Carol Lee. One thing I think I want to point out is, through our research, we've heard that elevating community needs can come from a variety of sources. It's not always the state, it's not always healthcare providers who necessarily have the closest view into what a community needs at any given time. And so I think with that in mind, would love to hear more about your work you do with faith leaders and the role they have and can play in elevating community needs.
Yes, thank you for having me at the North Carolina Council of Churches through our Partners in Health and Wholeness initiative seeks to work at this intersection of faith, health, and justice, um, seeking to educate, inspire, and mobilize faith communities to promote health and well-being across the state. Because we believe like faith leaders have a unique role in that they are deeply embedded in the daily lives of people, and they're often the first to hear about community struggles, whether that's around mental health, substance use, barriers to accessing care. And oftentimes people may not know where else to go, but they know their faith leader is a trusted place to start. And so these faith leaders become crucial voices in identifying and elevating the needs of their communities. And so we think that faith communities are both sources of insight and vehicles for translating community voice into policy and programmatic change. One of I just wanted to mention one thing is that a key piece of our work is helping communities make the connection between the issues they face and the policies that shape those realities. Many people, especially in faith settings, feel this sort of urgency to respond, like caring for the sick, feeding the hungry, but don't always see how their mission connects to policy. And so part of, what we do is try to help illuminate that connection, showing how Medicaid decisions, mental health funding, intersects with the ministry and work that they're already doing. And so one of the things that we say a lot at the North Carolina Council of Churches is we refract policy through the lens of faith. Because when people begin to see that advocacy isn't separate from their faith, but an expression of it, they often feel more empowered to speak and more committed to sustained engagement.
Thank you. I think that's really, really helpful to kind of hear a different lens of how you're working with those faith leaders to kind of see that different role. And so really appreciate those comments. And so Laquana, turning to you, after hearing from our panelists so far, representing these different perspectives, would love to hear from North Carolina Medicaid about, how you all are doing this, how you're translating community feedback into policy.
First, I'll say this is very timely. with all of the changes and things that are happening, not only just at our federal level, but also at the state level, it's important to ensure that we are collectively coming together to have these types of discussions. I think that as we have looked at our approach from the state level, and I'm glad to see Rebecca on today because she's been a vital partner in the work that we've been doing as far as being able to reach a number of our different consumers or members or beneficiaries, depending on what space that you sit in. It's important to make sure that we have that community feedback, and especially feedback that comes directly from those consumers. But from the department standpoint, we recognized and knew that, hey, there are times where a lot of that communication has been one directional, meaning we get on a call, we get on a webinar, we get an in-person meeting, and we are just shooting out information. And so it's been important to make sure we made some changes to those approaches at the state level as far as being able to make sure we receive that feedback. Some of the examples that I would give is one, with some of the new requirements that we have that have come down from CMS or the Centers for Medicare and Medicaid Services, we've been able to change what we considered, formerly known as the Medical Care Advisory Committee. And that has now been changed to two separate committees. Those committees now will be a Medicaid Advisory Committee, and now we also have a Beneficiary Advisory Council. And with dividing those, we now have the opportunity to not only just hear from our health plans and community partners who have been very vital in the work that we've been doing as far as being able to provide comments related to our policies and decision making that we're making at the state level. But we now have an opportunity to work with a group of beneficiaries or consumers that give us direct feedback and exactly what is their experience as they are using Medicaid as a vehicle to be able to have access to other health services. And with the Healthy Opportunities work that we've done in the past, other social drivers of health, such as housing, transportation, and being able to access food as well. So as we have now used this as an opportunity and we have launched, but we will have our first sessions and orientation starts next week. We are very excited about that. We'll be able to use that as a way to continue the layered approach that we have for bidirectional communication to ensure that we are receiving feedback in real time and taking that back to our decision-making process as we are making changes to those different policies. Another approach that I think that the department, that is something that we developed during our COVID time and in dealing with COVID-19 across many of our communities across North Carolina, it was the development of different work groups. And those work groups represented a number of, and I would say we did some community mapping. And with that community mapping, we were able to identify 215 organizations across the state of North Carolina to help us with being able to make decisions not only about what the communication or messaging should be in community, but how is it that we receive that feedback from those members, again, from those beneficiaries, to ensure that they are reflected in. And as you can see in some of the wording that I even have on the screen today, Medicaid for more people. We had folks like Rebecca and a number of other partners that were involved with those decisions as to how we're going to get that messaging out. And then finally, just our public comment process. We develop a number of policy papers that come out from the department, but we have to take the time to actually receive feedback on those different policies that are being developed. And so we have that opportunity to have public comment and receiving that feedback back from again, our consumers, our beneficiaries, our community partners, our health plans. They'll allow us to let us know as we are developing these policies in real time, again, receiving that feedback and making changes that reflect the needs of community. So I know that those are a number of different examples that I went through. I probably went through them very quickly, but we do invite you all to please, if you're interested in being a part of the work group, please look up our NC Medicaid Connecting Community Partners in Medicaid. So that there's opportunities there. If you're interested in being part of that public comment process, look up our public policy page. We have pages on our website where as we are releasing these public policy papers, you have an opportunity to go in and provide that feedback. We want to make sure, again, that bidirectional communication continues. Again, we are seeing changes with Healthy Opportunities where we have seen that there was not funding that was included in the budget process that we're going through right now. So there's opportunities to be able to give your voice. We're seeing right now that there's going to be some changes that come down from the federal level related to work requirements, related to how individuals are able to go in and provide updates annually, which will now change to twice a year now, every 6 months. Well, they'll have to go in and be able to let us know exactly whether or not they're able to still be eligible for Medicaid. So when we're doing redeterminations, those are direct impacts that we will see that will impact our members. And so it's important to make sure we receive that feedback from community as those changes are being made in real time.
Great. Thank you so much, Laquana. And that brings us to the end of our time for the panel, but I'd really like to, thank our panelists. I think we've heard so much around the importance of bidirectional communication and feedback. And by doing so, we can see that these community engagement strategies are leading to impact in policymaking. And so I really appreciate everyone's time. And with that, we are going to transition to hear a little bit more from my colleague, Katie Huber, around our research. I'll pass it over to you, Katie.
Thank you, Sam, and to all of our panelists, and good afternoon. My name is Katie Huber, and I'm a Policy Research Associate at Duke Margolis. Building on the discussion we just had about how community priorities can be translated to policy, I'm planning to spend the next few minutes talking through our research and community engagement processes and some of our findings before moving to our next panel discussion. So to provide a brief overview of our research process, our project has been informed by a community advisory council, as Sam mentioned, made up of representatives from organizations that are advocating for and working to address the healthcare needs of community members across North Carolina. Our Community Advisory Council has provided guidance and feedback on our research strategy throughout our project. And for this project, we also collected a variety of data, starting with stakeholder interviews. We talked with folks including North Carolina Medicaid staff, Medicaid health plans, healthcare providers, community-based organizations, as well as Medicaid agencies in other states. And we also conducted 6 focus groups with community members across North Carolina who had experience with North Carolina Medicaid. And our approach was to ask them what they need to be healthy and about their healthcare experiences through Medicaid, and then use that information to translate that to some potential policy levers. We just released a fact sheet with additional information on what we heard in those community focus groups, and we can share the link in the chat if you're interested in learning more. We also do have a quantitative arm of the study, and that work is still in progress and will not be included in our findings today, but will be released later this year, so stay tuned. And so together, all of this information we collected and informed our policy considerations. And so in order to identify kind of those priority areas and policy options, we looked for areas of overlap between what we heard from the stakeholders that we talked to in interviews and focus groups, and mapped that to a framework of value-based payment levers to advance community health and well-being. And so looking for those areas of overlap. We do want to emphasize that some of what we heard from the community cannot be directly addressed through value-based payment. And there's also concepts in the framework that were not raised by our research participants. So really just looking at that section of overlap there. But from that process, we identified 4 policy areas that came out of our qualitative research and framework, and those are listed here. The first is advancing whole person integrated care models and services, and this is the area that we're planning to focus our discussion on today. And I'll briefly describe the other areas, but we'll describe in more detail in a forthcoming policy paper. The second is exploring strategies to increase connections to the healthcare system and access to services. And so here we talk a lot about considering opportunities to encourage telehealth use among Medicaid providers and members, and also considerations for reimbursing providers with lived experience like community health workers and doulas. The third is centering patient and family care experiences and priorities. A lot of this relates to our first panel we just had around leveraging Medicaid's role in community engagement through advisory committees and other platforms, and also making sure we measure patient experience in value-based payment models. And fourth but not least, we also talk about reducing administrative burden for providers to improve high quality and timely care. So we'll start by talking through the first area focused on opportunities to advance whole person integrated care models and services. A major takeaway from our focus groups was that people are looking for more support to address their health-related social needs like housing and nutrition. And so some examples that we found of policies in Medicaid programs across the United States are shown here. In North Carolina, as LaQuana just mentioned, the Healthy Opportunities Pilots program has offered a comprehensive set of 29 services to address health-related social needs for eligible Medicaid members. We also found in several states across the country, there are states that use their managed care contracts to reinvest a certain percent, or to have their managed care plans reinvest a certain percentage of their total profits each contract year into community reinvestment initiatives, where they make investments to address members' social needs and improve social drivers of health. Our next policy option stems from focus group participants sharing how navigating Medicaid and different parts of the healthcare system can be overwhelming and challenging, and they desired more support with finding and accessing the services and resources that they need. We know that there are enhanced Medicaid care management services for certain populations in North Carolina, such as through the Tailored Behavioral Health Plans and the Integrated Care for Kids program, or NC Inc., which has family navigators that work with families and their integrated care teams to help them navigate and coordinate services across sectors to help families meet their health and well-being goals. Additionally, we found that California provides enhanced case management for some Medicaid members, where there's a single care manager that helps folks navigate across their health, community, and social services. And the third policy option we identified in this area is around the advancing behavioral health integration with other care settings and services like primary care. We know that North Carolina is doing a lot of work in this area. North Carolina Medicaid has established a collaborative care model consortium that aims to advance primary and behavioral health integration. The collaborative care model is an evidence-based model of care geared to those with mild to moderate behavioral health needs that includes co-located services where patients can access behavioral and mental health services in their primary care clinics. North Carolina has also taken a number of steps to increase adoption of this model in the state, including aligning coverage across major payers and providing capacity building grants to encourage uptake. Massachusetts also has an alternative payment model that incentivizes primary care providers to deliver care such as behavioral health services in the primary care setting. Participating practices in Massachusetts Medicaid's primary care subcapitation program receive increased payments for shifting to team-based and integrated care models and providing more advanced services in primary care settings, including behavioral health interventions. So now I'm pleased to turn back to Rebecca, who will build on this discussion with our next panel.
Great, thanks so much, Katie. And as Katie just previewed in our research findings, community members express the important role that Medicaid benefits play in their health and well-being. And when asked, they shared wide-ranging opportunities to improve their care access and experiences. Through this next panel discussion, we hope to highlight some of the leading examples where North Carolina and other state Medicaid programs are taking action on these priority areas through value-based payment levers. We want to focus, as Katie mentioned, our panel discussion on one of the policy areas identified in our research to hear our panelists' thoughts on how well these policy options can promote health and well-being, as well as any considerations for implementation. With that in mind, we're going to focus the panel on the first set of policy options, advancing whole person integrated care models and services. And again, just as a reminder, that includes expanding access to services to address health-related social needs, improving care management and coordination, and integrating behavioral health and primary care. So for this panel, I'm pleased to introduce Andrew Clendenin, who is the Deputy Director of Population Health at North Carolina Medicaid, Rashina Chalera, the Executive Director for North Carolina Integrated Care for Kids and an Assistant Professor of Pediatrics and Population Health Sciences at Duke University, and Sandra Wilkness, Senior Director for Behavioral Population and Public Health at the National Academy for State Health Policy. So if the panelists would go ahead and join me on camera, great. So nice to see you all. And bringing this group of panelists together, we are excited about the opportunity for the group to react to the research findings and share lessons learned from their diverse perspectives on implementation in other states as well. So, Andrew, I'm going to come to you first. One of the key needs that Katie was just highlighting that rose to the top in our focus groups was the need for help with addressing health-related social needs. This is an area where North Carolina has been an innovator with the Healthy Opportunities Pilots program. And early evidence points to reductions both in healthcare spending as well as unmet health-related social needs. So while we know there are ongoing conversations around funding for this program, we'd value hearing from you in terms of some of the lessons from this work and how this program is able to meet people's needs and helping spend Medicaid dollars effectively and efficiently.
Yes, thank you, and thank you for the introduction and invitations to be here today. The Healthy Opportunities pilots definitely are have been successful in providing needed services to our Medicaid beneficiaries. But I will say before I go into some details on that, Healthy Opportunities is a tool. It's one tool, and hopefully a growing toolkit of services that we are developing at Medicaid to address health-related social needs. As many of you know, Healthy Opportunities serves 33 of our 100 counties. So that leaves a lot of territory to cover to be innovative and to push our health plans and other partners to better serve our Medicaid recipients. So no matter what happens with the funding for Healthy Opportunities, we really do hope that this work is not anywhere near over, that we are just beginning, and that the Healthy Opportunities pilots, the learnings from that program will just better inform our work as we move forward, no matter what happens with the budget. But in terms of the Healthy Opportunities pilot, so it launched back in 2022. We focused on domains of food, housing insecurity, transportation, and interpersonal violence. The pilot, as has been said, and as we're seeing through our studies, is that it's showing that it's working exactly as intended. Our interim evaluation has shown that services saved North Carolina $85 per member per month, even after accounting for the costs of the services themselves. We're also seeing, in addition to savings, that individuals' social needs have decreased, and participating beneficiaries had fewer emergency department visits than they would have otherwise. And then I think also an important call out is just to make the point that that we're seeing a difference in people's lives as access to healthy food, a safe place to live, better home conditions for children with asthma. They're able to grow up without as many environmental triggers. All these things help families become healthier, individuals and families become healthier, live healthier lives, engage in school and work, and it helps the families spend less time stressing over having to engage a very complex medical system. So those are some of our early learnings and findings as a result of the Healthy Opportunities pilot, and we look forward, as I said, to the ongoing work in this area.
Yeah, I appreciate that, Andrew, and certainly highlighting, a win-win in terms of being responsive to what was clearly a top priority from the community members that we engaged in our research in terms of addressing, getting some additional support addressing health-related social needs, and that translation to saving Medicaid dollars. So appreciate you highlighting that. Sandra, I'm going to come to you next and kind of building on some of Andrew's comments. We know that North Carolina and other states have used what's called Section 1115 waivers to test approaches for improving health and reducing costs through evidence-based interventions that can address health-related social needs. So in a shifting policy environment, particularly around the use of 1115 waivers, what are other tools that states are using to tackle these issues, and what do you see working?
Yeah, thanks, Rebecca. And I have to start by saying we really value the work done through the NC HOPS program, and other states really look to North Carolina as an example of really solid work in this space, very promising. So I just have to underscore that. Other approaches, I'll touch on two brief examples. There, of course, there's a lot to unpack, so I'm happy to share more detail on the back end for anyone who's interested. One is Louisiana's Permanent Supportive Housing Program. And the other, I just want to hit a couple highlights on state approaches to paying for community health worker services with direct input from the workforce. So on the Louisiana example, it's compelling because it's a longstanding and successful use of a braided funding approach, which includes services covered through Medicaid authorities outside of the demonstration waiver authority, the section 1115 you just highlighted. And folks probably remember this, and you have your own real challenge in North Carolina recently, but following the devastation of Hurricanes Katrina and Rita in 2005, the state had an opportunity with some emergency dollars flowing into the state to establish a permanent supportive housing program, which combines deeply affordable rental housing and voluntary flexible tenancy supports, so supports you need to live in the home, and health and behavioral health service supports for people with very low incomes and complex health and behavioral health needs. The program is administered jointly by the state's Medicaid agency and housing authorities. And it's a really good example of cross-agency partnership among often siloed state agencies and resources. In terms of the braiding of resources to drive the program, on the housing side, the program braids federal HUD-funded project-based and tenant-based rental subsidy vouchers and community development block grant funds. It also layers in, because it also serves as the housing finance authority for the housing wonks out there. It also layers in a low-income housing tax credits approach to build and set aside deeply affordable units for permanent supportive housing. So that's already a lot of braided funding on the housing side. On the services side, the Medicaid authorities they use are 1915C, Home and Community-Based Services Waiver Authorities, and Medicaid State Plan Authorities. So those are outside of a demonstration. They also use Ryan White dollars for HIV, people with HIV. That's through HRSA. SAMHSA funds through cooperative agreement to benefit homeless individuals. Veterans Affairs resources for those who are eligible veterans to receive those services, and additional community development block grant supports to administer some of the programs. So that's an example of a very complex but very successful and now long-standing braided funding strategy. The other example I want to highlight very briefly is in the community health worker space. There's a lot of activity in the community health worker reimbursement space, and it fits so nicely with your research. It's really driven by renewed or new appreciation for the connective tissue that workforce really provides among state programs, health and human services systems, and communities. And just for folks' awareness, we recently put out a 50-state tracker on community health worker policies and Medicaid coverage. Real quick highlights. Over the last 4 years, the coverage went from 4 states to 20 using state plan authorities, and from 5 states to 15 using that 1115 demonstration waiver authority. Half of those are for services that community health workers can provide for pre-release from incarceration. So there's a lot of movement on the reentry space, and folks are seeing the value of CHWs there. Managed care plans also using administrative funds. But the last thing I wanted to highlight here is we, over the last couple of years, in partnership with our colleagues at Envision, which is a group of community health workers and allied policy experts, provided technical assistance to support state policymakers to sit down with community health worker leaders and co-design policy. Co-design may be a strong word, but inform policy, get to know each other, understand each other's works and lanes. We did it in 6 geopolitically diverse states ranging from Mississippi to California, and found that spending time to prepare all parties to address the specific policy issues, educate, empower, and pay for, to Rebecca's point, community health worker leaders to spend the time in this work and bring their wide range of community voices to the policymaking table. It resulted in change across the states, various types of policy change, including benefits and certification approaches and so on. And I'll just say to folks, given it just marries so nicely with their research, this work takes time, it takes preparation to be informed, and to make sure that the community folks are empowered to be part of the discussion. And it also can make a tremendous impact. Thanks.
Yeah, absolutely. Thank you, Sandra. And I think 2 really, really great examples that are critical lessons to kind of build on in North Carolina and other states as well, and the kind of connective tissue of the community health workers, even though we're just talking about one of our priority areas from our research today. Really, that theme, I think, carries across all the feedback that we heard from community members. Rashina, I want to come to you next, and maybe even picking up a little bit on the thread of Sandra's last comments on kind of collecting feedback from community health workers and translating that into action. Hoping you can talk a little bit about the North Carolina Integrated Care for Kids model and the lessons that you've learned from this innovative model regarding care management and family engagement, and how you're kind of taking that back to inform kind of future program design. And feel free as well to kind of elevate other examples where you've heard community member feedback on addressing these important topics of social needs and integrating behavioral health.
Thanks, Rebecca. Thank you all for having me. So I really agree. I would really love to build on some of the comments that both Andrew and Sarah just made. So Sandra just made. So let me first just give a quick overview of the Integrated Care for Kids model for folks who aren't as familiar with the model. So Integrated Care for Kids, or INC, is a model funded by the CMS Innovation Center, or CMMI. CMMI funds demonstration models across the country, as many of you all know, to really innovate how we deliver and pay for healthcare. So the INC models are the only child-focused models that are currently running. And North Carolina INC is one of the 7 INC models across the country. So these models have been, they had a planning stage from 2020 to 2022 and have been implemented since 2022. So in North Carolina, our NC INC model focuses in 5 central North Carolina counties. It includes about 100,000 eligible children who are enrolled in Medicaid, ages birth through 20. And it's really led in partnership across 2 academic institutions, Duke and UNC, as well as our state Medicaid agency. So the 3 primary components that are included in the Integrated Care for Kids model are using integrated data. And when I say integrated, I don't mean just medical and behavioral, but really cross sector. So bringing in schools, bringing in juvenile justice, foster care, really thinking about families. So how does a guardian's health need relate to a child's health needs? So bringing in all of that data to prioritize using data, which children or families may benefit from some of the care management supports that are offered via Medicaid. And then second, and the one that I'll really focus on, is our longitudinal care management model. And so our care management model is really focused on, building on what Sandra said, providing a family with one real quarterback or person who can help them coordinate across multiple systems and sectors. So if a child who is eligible and participating in INC, if the caregiver of that child says that they're facing food insecurity, the child may have undiagnosed ADHD, there are 4 siblings in the home, the parent may need help with employment, really that community, that care manager, who is often a community health worker, can really be the person that helps them streamline and coordinate across those services and create the communication across the different sectors as well. And we really do focus heavily on not just reinventing the wheel with economic resources. So yes, things like a food pantry in a clinical setting can be useful, but really there are programs like WIC and SNAP that have, and our social, our CBOs that know how to address social needs that we can connect families to by being that connective tissue, as opposed to reinventing the wheel. So really leaning on our colleagues across sectors to provide the wraparound longitudinal services that a child and a family can benefit from. We have interviewed multiple families who have children enrolled in care management, but also those who have declined participation, as well as those who started but then dropped out. And we've learned a lot from families and community members about what makes programs like this work. And so what I would first say is that people are confused. And so a lot of people don't know that they're aware, that know that they're eligible for certain services. And so we need to do a better job about making sure we're using things like human-centered design to figure out how we describe what care management is, how the health system can help families address social needs. Though these aren't things that, we're having everyday conversations about. So really making the language accessible when we're talking with families about this. And then a really important piece here is I think often because care management has been so focused on meeting clinical needs, meaning a care manager from a health system will call a family who's been discharged from the emergency room and say, hey, let us make sure you get back in for your next visit. But because we've really tried to be more comprehensive, we need to also be more flexible. And so instead of just trying to reach a family and saying, if we don't reach them within 30 days, we close out this case, we say, all right, we're going to work with the family for a year. And this family, they can text us, they can email us, they can also call us when they need us. It doesn't have to be on this prescripted every 30-day cycle, so that families, just like they reach out to me as their pediatrician when they need me, they can reach out to their care manager when they need them. We just haven't come along that far in how we design policy and guidelines around care management. And I think we really need to add some of that flexibility to be more family centered. So let me stop there. I know you have lots of other questions to get to, but I'm happy to talk more about any of those points later on.
Yeah, absolutely. And thanks, Rashina. And I love the analogy of care management being accessible kind of when and how people need it rather than kind of a prescriptive model, and really keeping that family centered. Well, I do want to hit on the other kind of priority area that we heard from community members in our research, and that is around behavioral health integration and thinking about strategies where we see behavioral health being integrated into primary care. So Andrew, I might come to you first on this. And as Katie was alluding to, North Carolina has invested in behavioral health integration through the work of the Collaborative Care Model Consortium and additional investments in capacity building as well. So could you share more about these efforts and how you all are incentivizing adoption across the state?
Yes, sure. So the collaborative care model is one of many really evidence-based models of integrated behavioral health care. But the state has, alongside many partners, has been really working to advance the model to increase uptake across the state through a variety of ways. So a partnership between DHHS, Medicaid, and AHEC and CCNC and others have provided reimbursement opportunities for practices that are participating. So we now have NC Medicaid and our 5 managed care plans reimbursing for the collaborative care model at 120% of the 2022 Medicare rates, which was a really significant win considering just a few years ago we weren't reimbursing at all with Medicaid. We also are seeing commercial plans and Medicare providing coverage, and we also just added recently the G0512 code for FQHCs and rural health centers. So reimbursement is there. We're offering practice support through AHEC, so technical assistance to practices that are beginning the collaborative care model. There's self-paced educational courses, peer learning collaboratives, psychiatric consultation being offered by NC PAL, as well as the NC Psychiatric Association, support for the behavioral health care managers that are embedded in clinics. So there's learning collaboratives and meetings for those individuals, ongoing trainings. CCNC has set up a registry so that practices can have access to a registry at no cost, which is a significant barrier for some. And then the capacity building funds you mentioned are there to to help with that on ramp. There are oftentimes, especially for smaller practices, significant costs that come along with implementing this model, and so this helps with supporting a care manager, a behavioral health care manager, psychiatric consultant, etc. Through this consortium, we have almost 90 practices now participating We know that more than that are billing across the state, but we're able to track and engage around 85 to 90 practices at this point through our collaborative work. And I'll just make one plug that, this is just, again, one model of integration. We're happy to see the whole kind of continuum of integration, we're starting to see more, starting with universal screening all the way up to evidence-based models of care. I think the true importance is that we're starting to see more of it, and that's really encouraging, especially for me who's worked in this for 20 years. So it's really great.
Yeah, thank you, Andrew, and I appreciate kind of the intentionality around creating access and uptake in some of the more rural and underserved parts of our state too, so that we can reach all Medicaid members. So we have just about a minute left for our panel. I know we could pretty much talk all day about these topics. So I'm gonna come to you, Sandra, for the last word here around, building on what Andrew was saying. Is there like one leading strategy that you would highlight that other states are pursuing and thinking about accelerating behavioral health integration?
Yeah, so yes to collaborative care model, and you guys have already discussed that. The other, and as was noted earlier, that's for folks with mild to moderate needs. The other side of that equation are things called certified community behavioral health clinics or similar efforts that are trying to bring those services to people who have more moderate to severe needs and integrate also across primary care, mental health, and substance use disorder. That's work in progress. Over half the states have a CCBHC or are part of the CMS demonstration, I think 30. So that's a place to look. And the only other place that I would suggest, because I know there's tons of interest in peer support specialists, Georgia's your go-to. Georgia was the first state that got a CMS approval to reimburse back in 1999. They have peer support services that run all the way across all of their arms of services and supports for behavioral health. And I just encourage everyone to go to their website. They have tons of information about how they do it.
Wonderful. Well, thank you all so much for providing some of these great leading practices that are being implemented both in North Carolina as well as across the country. And thank you to all of our participants for attending today's webinar to elevate community voices and identify opportunities for collaboration in Medicaid value-based payment design, implementation, and oversight. As Laquana noted on the first panel, this really is a timely conversation given all the Medicaid reforms being discussed at the state and the federal level. And just wanted to briefly highlight some of the themes we heard in today's discussion around the importance of these programs needing to work for people and making sure that feedback loops are bi-directional. Feedback loops and bidirectional communication are really critical tools for helping ensure that these programs work for people. We heard that community engagement efforts really need to empower people to show up as their best selves, as Rebecca was saying, and that this work is intentional. It takes time and can take a variety of different formats. We heard lots of examples today from a growing toolkit to advance community members' health and well-being through Medicaid and some of the different programs and policies that Rashina and Sandra and Andrew were highlighting. And certainly acknowledging that flexibility helps these programs be more person and family centered and allows folks to access them kind of when and how they need them. I want to just plug a couple of forthcoming publications from this work. As we mentioned earlier, we have a couple of fact sheets that reflect findings from the conversations we've had with North Carolina community members. They're available in both English and Spanish, and Alita from our team put those in the chat. We'll also have a forthcoming policy paper that's going to dive into more of our research on other states and the other priority areas that we weren't able to touch on in just a short 1 hour webinar today. But thank you all so much for the time today and this important discussion, and we look forward to hearing from you. Thanks so much.